I'm very delighted that the Epilepsy Foundation has pivoted to be able to do this online. These are parent education seminars. This is how this sort of talk started. But over the many years I've done this, I've been very fortunate that quite a lot of my adult patients have come, as well as my adolescent patients, and who want to learn about their own epilepsy. So I think this epilepsy talk is really for whoever wants to know about it. It's not just for parents, it's for teachers, carers, grandparents, but very importantly for people with epilepsy as well. The way this works is that I give you far too much information, just so you know, but the idea is you listen to the bits that are relevant to you or your child, and you have a little sleep through the bits that are not as relevant. And the reason for giving you so much information is so that you can understand where the child fits, or your epilepsy fits amongst all the epilepsies, because there are parts that will be relevant to you and parts that will not be relevant to you. So the first part of the talk will take at least an hour, I suspect. Then I'm going to give you a 15-minute break to have a cup of tea, etc. And then we'll come back and I'll give the second part of the talk, which is probably 35, 45 minutes. And then I'm very happy to take questions. I usually find there are a lot of questions that everyone wants to know the answer to. So that's where it would be good to bring up whoever would like to actually ask the question. It's great to see you in person because it makes it much more interactive. And also I can tell whether I'm making sense or no sense at all. So that really is important. So there's a tiny bit of history at the beginning, but really most of it is on current concepts on the epilepsies. The first hour is about seizure types, about epilepsy syndromes, about the very severe epilepsies we call the developmental and epileptic encephalopathies. And then after we finish the syndrome section, we have the break, and then I go into the tests. So that's coming, if you were wondering about that, and their relevance to epilepsy surgery, which is only relevant to a small proportion of people with epilepsy. But nevertheless, I know many families are wondering, could my child have that? And then a bit of the sort of basic framework around treatment. I do not go into every medication because that really puts people to sleep, I know, from medical school, I'm sure, but I'm very happy to take some questions. Clearly, I cannot give you a comment about your child's epilepsy. That requires a complex assessment by your own neurologist, but I am happy to talk broadly. Anyway, with that, let's get into epilepsy. And I guess the first thing to say is, what would we all like? Well, we'd like a cure. And in particular, can you see my mouse, James?
Yes, we can.
Great. If you could get your hands on some horn of a unicorn, that powdered is meant to cure epilepsy, but sadly we can't get our hands on it. This is just to say that epilepsy is not a new disease. This is back in 1480, and Raphael painted the Transfiguration. And here you can see a child having an asymmetric focal tonic seizure with one arm out, etc. And this is likely to come from the frontal lobe, and they're asking Jesus to cure the child. A couple more slides on history. Hippocrates, back in 400 BC, he recognized that epilepsy was inherited as a specific disorder of the brain, and that in susceptible individuals, the brain overflowed with phlegm that clogged the veins and caused convulsions. He didn't have it quite right, but nevertheless, he realized it could be inherited. And then if we move much to the Talmud, the ancient Hebrew text, that recognized against taking a wife from an epileptic or leprous family, as they recognized that epilepsy could go in families. Let's move forward a bit in time, and we'll go to Renaissance times. And this is pretty horrific. The ancient Scots instantly gelded any man with the falling sickness. And if a woman was found to be with child, she and her brood were buried alive. So you think we're enlightened in 2020. In the mid-1900s, the USA, 14 states forbade individuals with epilepsy to marry. That's horrendous, really. And I think we have improved, but maybe we're not quite there yet. So this is the most important take-home message for the day. We like to think people just talk about epilepsy as though it is one thing, but it is not one thing. There are many types of epileptic seizures, and I'm going to go through some of those today. And the take-home message is it's a group of disorders that we know as the epilepsies. So if your child has epilepsy and someone down the street has epilepsy, they're very likely to be different forms of epilepsy with different triggers, different causes, and different treatment. So it's great that you're online to learn a bit more about epilepsy. So what about the facts? Well, 4% of the population have seizures at some time in their life. Most epilepsies begin in childhood or adolescence, which is why it's really great that families want to learn about it. I've said already, epilepsy is not one condition, but a group of specific disorders which demand precise identification for treatment and research. And the very important point is most people with epilepsy are fully controlled and successfully treated. How else? What other important facts are there? Well, most people can have very normal lives. They have medicine that works like a charm and their seizures are fully controlled. They go to regular schools, they hold down normal jobs. Most can drive cars and most can bear and have families. So lots of good news there. So let's move on. What is epilepsy? Well, it's a brief electrical disturbance of the brain. And here is an EEG, a brainwave tracing. And you can see here the normal background waveforms that we all have all the time. And if we close our eyes, our EEG looks like that. But during an epileptic seizure, you have these disturbances of brainwave activity with epileptic activity. And then you have the seizure. And these abnormal brainwaves are associated with changes in blood flow and energy metabolism in the brain. And I'll show you some examples of that later when we do the imaging part of a talk. And of course, this reflects sudden chemical changes in the brain. So that's what epilepsy is. What are the types of epilepsy? And we're going to spend quite a while on this area because it's really complicated and interesting. So we have two major subgroups. We have the generalized epilepsies, where seizures begin on both sides or all over the brain at once. The main seizure types, and I'll come back to these, are absence, myoclonus, and tonic-clonic seizures. And the generalized epilepsies are associated with a range of very specific age-dependent conditions. That means they begin at specific ages and they finish at specific ages. What about the focal epilepsies? Well, here is where your epilepsy begins just in one part of the brain. And in this little picture, it's in the back of the brain, the occipital lobe. And the seizure pattern reflects that part of the brain where it begins. So the occipital lobe looks after your vision, what you can see. So people might get a visual hallucination at the beginning of an occipital seizure. Not always, but that's a very valuable clue to your pediatrician or neurologist. A focal epilepsy can be associated with a structurally normal brain or with a focal abnormality in the brain, such as a scar or perhaps a malformation. So what I'm going to talk you through now is the International League Against Epilepsy classification of the epilepsies. The International League Against Epilepsy is the main medical body for epilepsy. It's got a slightly odd name, has a very expansive website that I'll return to later. And I was honoured really to chair the new classification of the epilepsies in 2017, which was the first new classification in 28 years. And it was about 10 years of work. It was a lot of work. And this came out together with new seizure types, which I was also fortunate to be involved with. So let's start about the purpose of classification of epilepsies. And I do a lot of research and people think, oh, Ingrid's just interested in research, but I'm not. I'm most interested in helping my patients. And the purpose of classification of the epilepsies, we kept our eye on the ball through this. It has to be for clinical diagnosis to help patients have a clear diagnosis. And we've tried to make the words more transparent so that you and I are all on the same page and we can use words that mean what they say. So I'm going to return to this framework several times and use it to frame my talk, but this was the framework we developed. You begin with the type of seizures, and we denoted that they began with the onset. Does it begin in one part of the brain, focal? Is it generalized all over? Or do we just simply not know? You can know someone has epilepsy, but just not know between those two. From the moment I see a child or an adult with epilepsy, I'm asking myself, why do they have epilepsy? What is the cause? And the word etiology is the word we use for cause. And we brought in a group of different causes that are important. There are more than this group, but we tried to stick to the ones that really make a difference for treatment and helping our patients. So do they have a structural cause, such as an MRI abnormality that's triggering their seizures? Do they have a genetic cause? And we now know many genes for epilepsy. An infectious cause. This is particularly important in places like India, where there is a very common infection that will trigger seizures. A metabolic cause, much less common, but very important because it may be treatable. An ever-increasing number of immune causes now. And of course, it's important to say we don't know. And if we don't know the patient's epilepsy, every time I see that patient, I think, why don't I know? Is there anything else I should be doing in 2020 that I couldn't do in 2018 that now might help me to figure out the cause for that person's epilepsy? So with seizure types, the next thing we ask is epilepsy type. So you may have a child or an adult may have 3 different types of generalized seizures, and they have a generalized epilepsy. Or a child with a very severe epilepsy often will have a combined generalized and focal epilepsy. A good example of that might be something called Dravet syndrome. And then can we actually name the syndrome in which the child has? And then all along the way, we're thinking about their comorbidities, which is a medical term for associated medical conditions. And I'll return to that a bit later. So let's start at the very beginning. And we want to ask the question, the very beginning of our framework is, what are the seizure types that the person has in front of me? And we start from the point of view in the classification of it being an epileptic seizure, but you need to know it's really important. Many people come to first seizure clinics with non-epileptic events. And we as pediatricians and as neurologists have to be very good at pulling apart, has this patient had another event such as fainting, and the medical term for that is syncope? Could it be a movement disorder? Could they simply have a tremor? And there's another group of psychogenic non-epileptic events, which are not epilepsy, but are related to significant psychological distress and also need active management. And you can also see these psychogenic non-epileptic seizures occurring in people with epilepsy, which is why it takes very high level of expertise to sort out which is which, because you treat them quite differently. So in the classification of the epilepsies, we start off with the assumption that we're dealing with a seizure type. And we've excluded the non-epileptic seizures. So sometimes that's as far as we can go with our classification. We can just say it's this type of seizure and we have no further information. And that may be because the person's found having a tonic-clonic seizure, a convulsion. We don't know the beginning of it. We have an EEG and it's normal. So we just have too little information to be able to take this to the next step of classification. But we can say it's an epileptic seizure, and this is the first one. And often in both children and adults, we wouldn't treat the first one. Sometimes we would, but often we would not. So as I've mentioned, we begin by determining the type of onset of the seizure types. And so what about a focal onset seizure type? Well, this is where the seizure begins within one part of the brain, such as here, and then it may spread to involve the temporal lobe. So it's beginning here in the middle part of the temporal lobe and may stay just in that area, or then it may spread more widely to involve both sides of the brain. Now, I should have said that if I'm in the room with you, I would normally show you the angle of the cut of the MRI study. So this is an MRI scan. We call this an axial cut, and I hope you can see me, but it's a cut through your brain like this. And these regions are your temporal lobes. And here we're showing a temporal lobe, the middle of a temporal lobe, which is an important part for focal epilepsy, and I'll come back to that later, and how it can stay just in one area, or it might spread to both areas. And there are clues to that, and I'll come back to that. Now, with the focal epilepsies, I'm going to walk you through the classification. There's a basic version and an expanded version. The basic version, I think, is the important level for you to understand, but I didn't want to leave anything out, so I'll show you the expanded version because that's what your neurologist will be writing about and your pediatricians in their letter. So focal onset, and the first thing we worry about is, does the patient remain aware through the whole seizure, or are they aware just at the beginning, which might be when they have an aura, and then they lose awareness, in which case they have a focal impaired awareness seizure. So if you stop being with it at any time through the seizure, and it's a focal seizure, you have a focal impaired awareness seizure. But then there may be seizures where there are prominent motor features, such as stiffening or jerking. So you might have a focal aware motor seizure. Or then you might have another option is you might be focal, and then you might have an aura, which tells you it's focal. And then you might go from loss of awareness into a seizure where you fall to the ground, you're unconscious, stiff and jerking all over. And I'll show a video of a child having one of those, of a tonic-clonic seizure a bit later on. And then it's now called a focal to bilateral, that means both sides, tonic-clonic seizure. Tonic means you're stiff, and clonic just means jerking. So they're usually very dramatic, frightening events when the child has a tonic-clonic seizure, and it can begin focally or it can begin in a generalized manner. So in the generalized seizures, we have the seizures begin at some point within networks in the brain that are on both sides, as shown here. It can begin at the front, or in fact, it can begin at the back. And this includes both, and this is a cut through the brain like this, it includes both the cortex, but also in here what we call the subcortical regions. And we know these networks now, we're very well delineated, very well described networks. And if you look at this picture of a fMRI, so a special form of functional MRI, the red shows where it lights up, and this is with this generalized epileptic activity. You can see that the same areas light up, showing that we understand these networks quite well. So moving back to the generalized seizures, they can be motor, can be, for example, tonic-clonic, as we talked about, stiffening and jerking all over. And these look the same, tonic-clonic here and tonic-clonic there, but they just start differently, one focal and one generalized. Or they can be just staring episodes, which we've retained the name absence. And of course, there are some that are unknown, and they have motor features, which can be tonic-clonic. Again, you may not know whether it began in a generalized way or focal, and certainly if you have a young child, they can't tell you that. Or you may have a staring spell, but you don't know if it's generalized or focal. And then importantly, some people also have seizures, but we're not able to classify them at all because we just don't have enough information. So that's our basic framework. One thing I thought I'd spend a moment on, because I think it's really important, is how do you tell between staring spells, if they're generalized staring spells called absence, or if they're focal staring spells like a focal impaired awareness seizure. And there are all these points I have listed for you are very helpful, and we put them together to try and sort this out. So as soon as a person has an aura, that means they're having a focal seizure. But an aura is often very brief. It's like 10 seconds or a minute before a seizure. If someone doesn't seem right several hours beforehand, that's not a true aura. So an aura is where you're aware and you have a feeling, a sensation that you're about to have a seizure. And if that's reliable, it's extremely helpful for us because it tells us where in the brain your seizure is beginning. And it's a really useful finding. Now, sometimes as adults, we forget to ask the kids if they've got an aura, and they do, and you need to ask them, and they can sometimes tell them. You don't want to put words in their mouth, but for example, in a child with a visual aura, sometimes they can draw a picture of it, which can be really helpful. Now, an absence, because it begins over the whole brain, has no aura because it all begins at once, so the person doesn't feel anything. So you do not expect a child or an adult with an absence seizure to know it's coming on. They may know afterwards they've missed something, but they do not have an aura by definition. An absence seizure tends to be quite brief, typically 5 to 10 seconds, 5 to 15 seconds, but they can be much briefer too. They can be just 2 seconds, and they can go up to 30 seconds. A focal seizure can be brief, but typically is 30 seconds to a few minutes. With an absence seizure, I always think the best thing to pick it is the loss of facial expression, so that a child looks like they're with it and suddenly they have a dulling of their facial expression. And if that happens every time, then it's quite likely they may be having absence seizures and you need to do an EEG. The other thing that helps to differentiate is what they're like at the end of a seizure. With an absence seizure, a child will just come back to normal and they may have missed something, look slightly confused for just a moment, but then they're back to normal. Whereas with the focal seizure, they're often confused, they may be drowsy, and they may have headache, or they may not, but they often have these features. The pattern of occurrence of these seizures differs too. So many children with absence seizures will have them daily, and sometimes even many per day. Whereas focal seizures tend to cluster, so they'll have 3 over a week, none for 3 weeks, then 3 over a week. So you put all these points together and that helps you to figure out what you're looking at. So I hope that's been helpful for trying to figure out the different types of staring spells. Now, I don't want to overwhelm you, but this is the expanded version of the seizure types for your neurologists and pediatricians. And I'm not going to go through all of them, but I am going to talk about some of the major ones. So just pulling this apart, you'll recognize the same headings we've just talked about, but in the focal group, you can have focal impaired awareness motor seizures, and these may involve automatisms. And that is, the word is a funny word, but what it looks like is what it means, automatic movements. So common automatisms can be, I hope you can see me, a sort of bit of mouthing where you might be swallowing or kissing or laughing or smiling, and they're automatic mouth movements. Or you can have automatic hand movements. So in the video I'm about to show you, which is quite an old video, but it's a good one, you see a little boy who's writing, and then he looks like he's fiddling during the seizure, so automatic hand movements. We can have atonic seizures, I'll come back to those. We can have epileptic spasms. Hyperkinetic means, and I'll describe that a little bit more, and it's shown in the video. Hyperkinetic means very active, hypermotor, where you thrush around. And you'll see a little boy on the video who has a frontal lobe seizure, and he thrashes around it's only about 20 seconds, but you can see that he's not quite with it, and then suddenly he becomes with it. We also have here non-motor features. The most common would be just behavioural arrest, and a child or an adult can just stare for about 30 seconds or 3 minutes. Sometimes they may have motor features such as version, where their head and eyes move to one side, like I'm doing now. They may have features like changes in thinking, and emotional or sensory features. And these can include tingling in a hand or a leg. Now, obviously, a young child can't tell you that, but an older child or an adolescent or an adult can tell you. The cognitive or emotional ones might be changes in sensation, like a common one for temporal lobe epilepsy would be déjà vu. Now, I'm sure you've all experienced déjà vu. That means French for already seen. And it's that sense of you feel like you've sat here and listened to me before, but you know you haven't, but you feel like you have. It's just a moment, it's fleeting when it's normal déjà vu. And that's the sort of cognitive aura that you can have. And then we've already talked about how a focal seizure can progress slowly or can progress rapidly to a tonic-clonic seizure. So for example, if you have déjà vu for 10 seconds and then go straight into a tonic-clonic seizure, then you've just got straight here, focal to bilateral tonic-clonic seizure. If you have déjà vu and you stop and stare and look to the side for a minute and then go into a tonic-clonic seizure, then you have a focal impaired awareness seizure, which goes or evolves to a focal to bilateral tonic-clonic seizure. Now, with the generalized ones, I'm not going to go through them all in detail, but you'll see they're very similar. I will point out there are several different types of absence seizures. I'm very happy to take questions about that later. But the most common are typical absence, like the little boy I'll show you in the video. And there are some rarer forms of absence, myoclonic absence, and absence seizures with eyelid myoclonia, which look different but can be very frequent. And then this is much the same as you've seen before. All right, time for a little breather, not your coffee break yet, but we're now moving in to the different subsections of seizure types. And so this is now just to talk about generalized seizures, and I'm going to go into syndromes a bit later. And the most common generalized seizures, there are a whole list there, but these are the ones you need to know about. Absence, and we've talked about that at length. Myoclonic seizures are interesting. You all know what they are because you have them as you fall asleep in bed at night. It's called a sleep jerk. It's not an epileptic seizure. And it's where you suddenly jerk as you're falling asleep. Some people say it's like falling off a log. If you don't do it yourself, your partner probably does. And so you have that, you know exactly what I'm talking about. Now, if you have these little jerks, which can be really quite big or can be just one arm or one leg, and you're having them at breakfast time, people might just toss the Wheaties across the room. So we sometimes call them the Wheaties jerks. I've had other people describe them that they have them, young women, when they're doing on their makeup in the morning. So they tend to be around awakening in the morning or more later in the day when you're tired. And then the other generalized seizure we've already talked about, a tonic-clonic. So tonic means stiffening and clonic means jerking. Now, sometimes people will go backwards and stiffen with quite a long period and then start jerking, or sometimes the stiffening will be fairly not noticeable and the jerking's obvious. It doesn't make a difference which way this is, but you can't keep standing up with a tonic-clonic. You do fall to the ground, or if you're in a chair, you might fall to the side or fall backwards. And they're very frightening events, and parents usually think that their child is dying the first time they see one, and the child is unconscious. If the child is conscious, it is not a tonic-clonic seizure. So I wanted to also talk about drop attacks, which are part of generalized and focal epilepsies. And you can see they're very nasty seizure types. And here's one of my patients having a drop attack. Drop attacks come in multiple types. And this needs a really good video. This is a home video. Can't tell you how wonderful home videos are. If you're worried about events, video them. Don't just video one, video 3 of an event, so your neurologist can look at the 3 and compare them. So in drop attacks, you can have tonic ones where you stiffen and you fall back like a lead pipe. Atonic, where A means loss of. Tone, where you crumple like a rag doll. When you're young, you can get knocked off your feet with a myoclonic one, a jerk I just described. When you're older, that doesn't happen. Or you can have a combination of a jerk and then a drop, a loss of tone, like this little girl has. And even epileptic spasms, and you'll see them in the next video, in a standing child can certainly cause a drop attack. So just to watch that again, you can see she's talking to her mum, and there you see what a nasty thing this is. And with a drop attack, you can actually really sustain nasty injuries. You can if you fall forwards, you can break your jaw, you can cut under here. They're very scary events and often seen in the severe epilepsies, not usually seen in the mild epilepsies. Now I'm going to next show you a video which is old. So it calls the focal seizures, partial seizures. It's been done from the Sydney Children's Hospital by my friend Annie Bai, Professor Annie Bai, I should say. And all the children have a box on their head, which is a video EEG monitoring. So it's a little bit, that takes your eye for a moment, but just ignore it. It's the old-fashioned way. But they're quite nice examples of the different types of seizures. And I'm hoping they will help you to diagnose what might be going on for your child. So this begins with the focal seizures. It looks like, forget that terminology, it's old. And we'll now go into the seizure types. It's good that the audio is not playing, I believe. Could you just confirm that you can't hear the voiceover on the video, James?
That's right. It appears to be just the video.
That's good. That's better, actually. So there you see a little girl. She's with it. She's saying to Mum, I'm having a seizure. And she's got some unusual posturing of her hand, which we call dystonia, abnormal tone. Now we're going to a focal impaired awareness seizure. And you see a boy, he's playing with something, he's having the monitoring. And then at some stage he loses awareness. And my suspicion is it's when he gasps his tummy now, he's having an aura. And I think this will be an abdominal aura. He feels uncomfortable. And now his parents got up to press the button on the machine. And now he's into the seizure and he's having what we call automatisms. And I mentioned before automatic movements. Now they can happen both in focal and in generalized seizures. And these are movements that are semi-automatic. He thinks he's doing something, but they're not making any sense. And he is off the air. I think he's still off the air now. And he's now might be coming around. Now, this is a different type of focal seizure. Again, the old terminology, ignore that. And this is the boy with the hypermotor, overmotor. So he's into the seizure now. He might have been falling asleep. We don't know. He's still in the seizure. This is all seizure activity. It's semi-purposeful. It looks like he's trying to do something, but he's still in the seizure. Dad recognizes it because they're always the same. And now it's ended. So very brief seizure. But one of the features about seizures is that they're always the same. And again, the new name for this is focal to bilateral, means both sides, tonic-clonic, and then generalized tonic-clonic. And I think with this seizure, we don't know which one it is, but it's a little toddler. And now the child's into it, stiffening all over, all the arms and legs up. They're very careful. This is beautifully managed by the parent. They make sure the child can't hurt themselves. And then the child's stiff. And you can see the twitching here is quite subtle. As people get older, often the twitching is not subtle at all. It's much more obvious. But the severity of how marked the twitching is doesn't make a difference. Also doesn't make a difference if you are incontinent, as in pass urine or not. That's just a matter of your bladder, whether it's full and how good your sphincter is. Now the child here is into an absence seizure, and now he has these automatic movements, automatisms, and then now the seizure ends when he tickles his nose. And now they play it again, so I'll let you have a look and you'll see the EEG superimposed, so you can see the difference. So that's a normal EEG. Now he's into the seizure, staring, a little bit of head jerking, very subtle, automatic movements, still in the seizure, and that's in. So the EEG is a little bit delayed on the video because of the technology at the time, but you can see there very clear changes. Now, this is an adolescent with juvenile myoclonic epilepsy, and I'll talk about that a bit later on in the seizure, in the syndromes. But they're having the jerks. It's very sudden and very brief, and this is a myoclonic seizure. And there you see it. That was a little cluster. You can have just a single one, and you can see the EEG with that is quite dramatic. Now we're going to talk about the drop attacks, and I've already mentioned to you they come in about 5 varieties. But I think the first one is the lack of tone. It's very sudden, and you can see how the child can really hurt themselves with this. And there you go, and the child just falls down with lack of tone. And now we're going into a tonic seizure. I'm just trying to see, yeah, so there we have a tonic seizure where the child goes stiff all over. And this is actually an epileptic spasm, which tends to be a bit shorter than a tonic seizure, under 3 seconds, and it's a spasm. And then this goes into neonatal seizures, newborn seizures, which are quite different. So I think I'm going to leave them there. So these are the terms we no longer use. They have gone out, very old-fashioned terms, and you shouldn't be using them. And hopefully your doctor has moved to the new terminology, but they won't all have done so, but we'll get there eventually. So what about cause? I just wanted to spend one slide talking about cause for a little moment. Again, just because this is what I teach the doctors, and I think it's really important that the families understand this as well. We have all these different potential causes, but they're not exclusive. You don't just have structural or just have genetics. So for example, tuberous sclerosis is associated with many severe forms of epilepsy, and that has associated with structural abnormalities of the brain. I'll show you an MRI of that a bit later. But we know that tuberous sclerosis is a genetic epilepsy. So it is an epilepsy that's caused by mutations or abnormalities of a gene in 2 different tuberous sclerosis genes, TSC1 or TSC2. So it's both genetic and structural. Another example was a metabolic condition called glucose transporter 1 deficiency. And this is metabolic because it's around glucose being transported into the brain. It's not working properly. And we know it has a genetic cause, and we know the gene for it. And this diagnosis is important because it has a special treatment, the ketogenic diet. So thinking about cause really affects treatment. And then we talked about epilepsy syndrome. So what do we mean by the term epilepsy syndrome? Well, this is an old-fashioned concept in that it was first defined in 1989 as an epilepsy characterized by a cluster of signs and symptoms that tend to go together. These may be all the different types of seizures, and I'll give you examples of this as we walk through the seizure types, the cause, the parts of the brain, what might trigger seizures, the age it begins, which is very important for all epilepsy. How severe is this epilepsy likely to be? How long will it last? Is it mostly just daytime or mostly at night? And sometimes the syndrome will give you an idea about prognosis, which means will the child grow out of it? One syndrome doesn't always have the same cause or the same prognosis, but often it's useful. So that brings us to the final part of the classification, which are the comorbidities. And I just wanted to give you an example of the sorts of associated features that you can see in people with epilepsy, and particularly in the more severe epilepsies. Quite a proportion have autism spectrum disorder. In the very severe epilepsies, many have developmental problems and intellectual disability. Many have behavioural problems, gait issues, gastrointestinal issues, so that might be with eating, with drooling, with constipation, and many have sleep problems. So these issues can occur in people with normal intelligence and epilepsy, but equally they're much more prominent in the children and adults with the developmental and epileptic encephalopathies, which are the most severe group of epilepsies, and one in which I spend a lot of time. Now, I know that many of the people listening to this will not have a severe form of epilepsy, their child or the adults listening. But where it is really important to the families that have children or adults with developmental and epileptic encephalopathies, I want to spend a moment describing what does this mean, because it's a very complicated idea. An epileptic encephalopathy refers to the person having lots of epileptic activity in their brain. And it's this ongoing barrage, this pummeling of the brain with epileptic activity that affects learning, intelligence, and behaviour. Not always behaviour, but sometimes. And this is quite important because it actually stops the child from developing and they may lose abilities. And at the back here, I've put an EEG that comes from a person with Lennox-Gastaut syndrome. And this epileptic activity, and you can see here these epileptic discharges that I'm pointing out, occur every second in that person's brain, whether they're having a seizure or not. So you can imagine you can't learn if you've got this ongoing barrage of epileptic activity. And we know that most of the patients with epileptic encephalopathies, they have frequent epileptic activity, though this can wax and wane. They have frequent seizures, typically many types of seizures, and they have developmental slowing and often regression, which means loss of skills, or their development might just slow, or they might actually lose skills. So putting this into picture form, here's a lovely little 21-month-old girl I met. And when I met her, she was having a focal tonic seizure every 5 minutes. She had very frequent epileptic activity. It was going all the time. She had background slowing of her brain. Her brain just couldn't learn. And with that, although her development was never normal, she actually lost skills. And you can say, well, what does this matter? Why? Well, it matters a lot because it may affect how we treat a child or an adult. So the first thing is perhaps they have a structural abnormality, and that structural abnormality is leading to this barrage of epileptic activity and the child can't learn. Now, I mentioned tuberous sclerosis a moment ago, and that's where you have different skin markings on your face, you can have on your nails and things. They can be quite subtle, but your brain has many different areas of abnormality, which I'm pointing out to you now, called tubers. These are not cancers, but they're abnormal formations of the brain. Now, if you can figure out which of these tubers is causing the seizures, and some are more likely to be epileptogenic, it's a fancy word for meaning causing seizures, and you can remove the ones that are bad and the others aren't doing much, then you can stop this process of an epileptic encephalopathy, and that process can resolve and that child can get on with learning and developing. Equally though, if you have an epileptic encephalopathy that's genetic, and here I'm showing you the sodium channel, which is in the cell membrane, and this is the alpha subunit, and many of you will know about the sodium channel gene SCN1A, or another one is SCN2A or SCN8A. If you know what they've got, which mutation or abnormality of a gene, then, for example, and I'm using just one here, Dravet syndrome, we know that some drugs will make a child with Dravet syndrome worse. So the big one is Tegretol or carbamazepine. I'm sorry, I've got medical speak here. And we know that some drugs will be really good for them, like fenfluramine, stiripentol, or topiramate. And we know if you use the right drug and you get rid of the bad drug, then that child can get on with developing. Doesn't mean they'll be normal, but you can see them make developmental gains because they're on the right medication. So understanding that your child has a developmental encephalopathy is really important because it means you need to treat them quite aggressively with somebody who understands the disease. Now, in the 2017 classification, we changed the words to be developmental and epileptic encephalopathy. And that's because we recognized that many of these children have a genetic problem that causes a developmental problem in its own right. And then, if you like, on top of that, you get this epileptic encephalopathy process. And that actually makes it even worse. Like the little girl I showed you, her development was never right. She then had seizures every 5 minutes and lots of epileptic activity, and she lost her abilities. And here there may be something you can fix with choosing the right anti-epileptic drug or anti-seizure medicine. So like in Dravet syndrome, stopping the Tegretol and starting the topiramate. And with time, we're going to move to calling these by the gene name when you've solved it for that child. So in this little boy I'm showing you in the video, he has a potassium channel gene called KCNQ2, and he has a developmental and epileptic encephalopathy. And as you can see, he has cerebral palsy, he has profound intellectual impairment. And although his seizures stopped when he was 2 years old, here you see him at 4 years of age. He's not having seizures there, but he's still having very profound impairment. And interestingly, when he became 8 years of age, he developed a picture of Lennox-Gastaut syndrome, so his seizures came back. So these are very severe diseases. And then together with those, we now recognize that many of these very severe diseases can also have movement disorders. And here you see a 6-year-old boy, and he has what we call stereotypies, a movement disorder, and unusual arm movements. Then you see a little girl who has cerebellar problems, and another little boy with hypermotor movement disorders. Now, these children all have different genes. I've just shown them at the bottom, but they all, you don't treat the movement disorders in the way you treat epilepsy. So it's really important that your neurologist or pediatrician figures out whether it's a movement disorder or a seizure disorder. So within this large group of developmental and epileptic encephalopathies, which can begin at any age, we have a range of syndromes. The commonest is infantile spasms, which used to be known as West syndrome, Lennox-Gastaut syndrome, Dravet syndrome, and slightly less common is myoclonic atonic epilepsy. There are much rarer ones, which are Ohtahara syndrome, epilepsy of infancy with migrating focal seizures, the epilepsy aphasia spectrum. And then there are some that are more focal, such as we talked about tuberous sclerosis, Rasmussen syndrome. But what's important is there are many children that fall into this blue sea around it. So you can have patients that do not fit a clear classification. The progressive myoclonus epilepsies often begin in adolescence or even into adult life. So some of the children can just have you can't classify them, but they have an early infantile developmental and epileptic encephalopathy where they begin under 3 months. They can have infantile between 3 months and 2 years, or they can have them beginning at any age. So these are very complex diagnoses, but it's important to know that your child might have one and not fit into a neat syndrome. So what's the cause of these devastating conditions? And the answer is that they're almost, well, not always, but mostly, I would say at least 80% have a genetic cause, and we now know more than 300 different genes involved, and this is taken from a figure that we did of a review back about 40 years ago, and they involve a whole lot of different biological functions in the cell. I'm not going to go through these, but just to tell you many different functions. So how can you learn more about this group of diseases? Well, I'm going to talk a bit more about them now, but if your child fits into this group, I really encourage you to go online and look at this, Genetic Epilepsy Team Australia. And this is led by a group of incredible parents whose children all have different genetic diseases. And they've now had 4 annual conferences. The last one was online and was a short version, but usually they're face-to-face and allow, a couple of hundred people to talk about the different things they're experiencing with their children. And they usually stream them around the world. And I know we have people listening in from other parts of the world today. And this is a fantastic supportive community, no matter what your child has, whether you have a diagnosis of a gene, but even if you don't, if you have a developmental and epileptic encephalopathy, the things this group talks about will be incredibly valuable for you. And if you go to their URL online, just search Genetic Epilepsy Team Australia, you can watch the previous conferences and look at some of the science about how we might make this better. Okay, so now we're going to head into our syndromes, and I realise you're going to need a break soon, so I'm going to try and motor through these without being too lengthy. One of the big groups is the idiopathic generalized epilepsies, and I know we have a number of families online with children with these, or adolescents. These are people of normal intelligence. They may have tonic-clonic seizures, they may have absence, and they may have myoclonic seizures. So if I see a patient with any one of these, I go looking for tonic-clonic absence and myoclonic seizures. They're otherwise normal, their MRI is normal, and their EEG background is normal. Their EEG shows 3 Hertz generalized spike wave, and I'll show you that. And these people are usually well controlled with the right anti-seizure medicine. Now, there are 4 main syndromes in the idiopathic generalized epilepsies. I'm happy to take questions about any of them, but I'm going to talk about the commonest, childhood absence epilepsy and juvenile myoclonic epilepsy. So let's start with the childhood absence epilepsy. And just to be clear, the old name for this is petit mal. We no longer use that name. It went out about 20 years ago or more. So this begins typically at 4 to 10 years of age. 4 to 8 years would be the most common. Children have many staring spells per day, and often they don't have generalized tonic-clonic seizures at this age, but 40% of them will go on to develop them in adolescent life, so when they're teenagers. And these individuals of normal intellect. And here's a gorgeous picture put together by my colleague Sam Berkovic, and that's from his studies of twins. And he went back and looked at William Lennox's twin series in the 1950s. And here you see the gorgeous Constance and Catherine, identical twins, dressed identically. And they both developed absence seizures at 6 years of age. And they almost have identical EEGs, showing you that it's genetic. If you've got 2 twins with the identical genetic makeup and they have the same disorder, you know it's a genetic disorder. And here is a lovely example of 3 Hertz generalized spike wave, which is the EEG of typical absence epilepsy. And here is the EEG more specifically, and you see 3 of these spike and wave complexes in 1 second, and some people call them a dart and dome, and you can see me going over that. And here the child abruptly loses awareness, and then it ends, and the child comes back and is with you. And this one is lasting about 7 seconds. So it's a typical EEG for typical absence seizures. So the EEG has 3 Hertz generalized spike wave activity involving the whole brain. The cause is genetic, but for most people, we do not know the gene yet. We're just beginning to know some. So it's genetic, but we don't know the gene yet. And it doesn't mean that it's inherited. And I'm happy to talk about that a bit later. The treatment of choice in children is usually sodium valproate. Now, I've tried to put here for you the trade name, the commonest Australian trade name. It will be different in other parts of the world, and give you the proper name, which is how I should teach, which is valproate or Epilum. The old-fashioned drug, but sometimes can be really good, is ethosuximide and Zerontin. Lamictal or lamotrigine can be good, and there are a bunch of other drugs, and these children do very well. And as you've already heard, 60% of them will grow out of it in adolescence, and 40% might go into adolescent epilepsies, of which the most common would be juvenile myoclonic epilepsy. So turning now to juvenile myoclonic epilepsy, this begins in the juvenile age range, and by that we mean adolescence. So onset is typically 12 to 18 years, but it can be from 8 to 20, 24 years. But this is the typical age. To have this epilepsy, you must have those myoclonic seizures, which are the single jerks. And most of the patients go on to have generalized tonic-clonic seizures, and 1/3 will have absence seizures. The absence seizures differ a little bit to typical absence in childhood because the child may have some semi-retained awareness. So they may know they've had a seizure, whereas a child typically will not. And they may be harder, therefore, to pick because they may look like they're almost with it. And if you're not sure, start testing them. Ask them what 1 + 1 is. Don't say, are you okay? But just check out whether they do know what you've asked and whether they can answer correctly, or who am I, or what day is it, something like that. Juvenile myoclonic epilepsy is very much affected by the sleep-wake cycle. So if you stay up all night, you're very likely to have a seizure. And that's unfortunate because adolescents do that very well. This also occurs in people of normal intellect, and 4% of people with juvenile myoclonic epilepsy have had childhood absence epilepsy. Now, interestingly, the EEG is also generalized. It involves the whole brain at once, but it's much faster and not as regular as the beautiful pattern I just showed you in childhood absence epilepsy. So if you see here, it has this polyspike, lots of spiky bits, and then it has a much faster frequency here. So it's a different EEG, even though it's still generalized. It's faster, polyspike. Again, this is caused by genes. Today, we only know a few of the rare genes, but we do not understand the genetic makeup of most of these patients, of 98% of them. The treatment here is in males, or in it's basically Epilum, sodium valproate. We can't use that in females of childbearing age because it's bad for babies and you just don't know when someone might fall pregnant. So in females now, we would tend to go for levetiracetam or Keppra. We might do that in the males, but Keppra can be associated by irritability and anger in about a third of people. So certainly in a male, I would start with the valproate first. Now, importantly, lifestyle factors are the most important thing for this epilepsy, and you need to avoid tiredness. Very easy to do when you're an adolescent. Not, I'm joking, because people they tend to stay up late and party late. But, you know, I tell my adolescents with this syndrome, if you know you're going to a party or you're going to have a late night, have an afternoon nap in the afternoon beforehand and try and get a credit on your sleep. Don't have alcohol or just have one glass and nurse it all night. And also, this is the group that are most photosensitive, which is where the strobe lights might trigger a seizure. So if there are strobe lights, get out of the room. These people do very well in terms of being fully treatable, but it's not common that the seizures go away. So they may need medication for life, but they're often fully controlled on one drug and they're very normal, and otherwise life is very normal. So I've already spent a little bit of time on the developmental and epileptic encephalopathies, but I'm just going to talk about Lennox-Gastaut syndrome for a moment so you get the feel of this at a more specific syndrome level. These patients have multiple seizure types usually. Very common to have myoclonic, tonic, atonic for drop attacks with loss of tone, or head nods, they're often atonic. Tonic-clonic seizures, absence seizures, and even focal seizures. I should have had that in there. They usually have intellectual disability. Their EEG shows slow spike wave activity, and I'll come back to that in a moment. They really are hard to get the seizures under control. They do not do well, and they often end up on many or several anti-epileptic drugs or anti-seizure medicines. And here are just some of the syndromes in this group. And here is one of my long-term patients who was having lots of drop attacks at the time. And you can see here when he's about 4 years of age, he's got injuries from the drop attacks. He's wearing a helmet to protect his head with these nasty seizures. And the lights are on, but nobody's home. He's not very with it. And then we put him on a new anti-seizure medicine, which was new then, now it's an old one. And it made a big difference, much more with it. He's looking with us, he's not having his drop attacks, he can take off his helmet, which is great. The sad thing is that little dimple is an injury. It resulted from an injury from a drop attack, so it wasn't a natural dimple. You know, that just tells you about how nasty these diseases are. So Lennox-Gastaut syndrome accounts for 3 to 10% of childhood epilepsies. It begins between 1 and 7 years, and 50% of children with infantile spasms go on to have Lennox-Gastaut syndrome. Boys more commonly affected. There are many causes, some of which I've listed there, but I haven't listed them all. The most common, I think, that we would see these days, apart from genetic causes, would be brain malformations. And indeed, brain malformations can have genetic causes. So here you see MRIs through the brain with this sort of angle. And this is, which I'm showing, I hope you can see me. And here you see a very severe, probably the most, well, one of the most severe brain malformations, where you have a smooth brain. It's called, listen carefully, the grey matter of the brain that does our thinking and triggers seizures is much thicker than it should be. The differentiation between the grey matter and the white matter, which conducts the messages from the brain, is fuzzy, grey, very poor grey-white differentiation, we call that, and it's smooth. And these children always have seizures and used to have a very poor lifespan, dying by about 2 years of age, but now they live considerably longer. This is another malformation, which interestingly can be caused by the same gene, with the girls having the milder malformation and the boys having a severe malformation. And here is called double cortex. So here, when the brain forms, the neurons in the brain line the ventricles here, which are just fluid-filled chambers in the brain. And those neurons go out to form the cortex in all of us as our brain develops when we're in the womb, in the mother's uterus. And these neurons have migrated halfway, but not made it all the way out. So it's called double cortex. And here's your double cortex. And that's usually associated with focal seizures and epileptic spasms, often very hard to get these seizures under control. So the hallmark of Lennox-Gastaut syndrome is tonic seizures. They must have tonic seizures. They often, but not always, have atonic, loss of tone seizures, and they typically have absences, which we call atypical absence, because they have a slower EEG, they may be longer, they may start more subtly and finish more subtly, so you may not be able to tell when it begins and when it ends. And this is particularly challenging in individuals with severe to profound impairment. The EEG shows slow spike wave. These patients usually have intellectual disability, and many, but not all, have behavioural problems. And the seizures continue into adult life. And this is the EEG I showed you a little of before. This is slow spike wave. The discharges are seen over most of the brain. This is 1 second, and you can see there's a discharge here, a discharge here, here, here. And it's often impossible to turn that off. But if you can, the child's development improves, and you will see that as parents. So the outcome here is poor. These children have severe intellectual disability, sometimes even profound. They have a poor outcome. Is that because they have this ongoing learning problem because of the epileptic activity, which we can call non-convulsive status epilepticus? That just means ongoing epileptic activity and you're not with it. Or is it because they end up on multiple medications, which is true. And sometimes if you pull them back, they can become more alert. The deterioration in these individuals may last just a few years, and then it may plateau out. Poor outcome is associated with the earlier onset, so the spasms babies often don't do as well, or if they've got a major structural cause, such as that smooth brain I showed you, where you can't change the structure of the person's brain. So that's a bit of a depressing note, and I want to finish with the last group, which is the focal epilepsies. And these is a better group in terms of it's not as depressing. And in these ones, individuals must have focal seizures, and they may have focal to bilateral tonic-clonic seizures, or they may just have focal to bilateral, so one and or both. They have an aura, which tells them the seizure's coming on. Many of these are in sleep, in children particularly, and then they always look the same, which is what I mean by the term stereotyped. And in the mild syndromes, their brains are otherwise normal. They have classical EEG features, and they respond very well to anti-seizure medicines in the milder ones. The best known one is benign epilepsy with centrotemporal spikes, but another important group are the benign occipital epilepsies of childhood. And although I don't have slides about that, I'm happy to speak to that if you have questions. So let's take the common one, which is always, I say, if you're going to have epilepsy, it's the best one to have. And this is an epilepsy that typically begins at 5 to 10 years of age, but can begin as early as 3 or as late as 13 years. It is more males than females. It has a number of names. The one that pediatricians tend to use is benign focal epilepsy of childhood. The one the neurologists, the older one, is benign Rolandic epilepsy, which refers to the part of the brain involved. And I can tell you the new name coming is self-limited epilepsy. And the reason for that is that no epilepsy is truly benign. So we've changed the term self-limited. So these children typically have seizures in sleep, maybe half an hour after they fall asleep or an hour or two before awakening, between 5 and 7 a.m. They commonly have drooling, dribbling. That means they can't speak. They may have half of their face going stiff or jerking. They may have involvement of an arm with clonic, or tonic means stiffening. Their aura is very important if they can tell you, and a young child probably can't tell you, but they may describe tingling in their gums, around their cheek, or in their mouth. About 60% can be aware, so they might come to the parental bed at 5 a.m. and wake you up, and they can't talk, and they're drooling, and they're trying to tell you something's wrong. And they could do this in this time they're aware, but some of them are not aware, and some of them just have bilateral tonic-clonic seizures. So you might be in the caravan sharing the room and you suddenly hear this noise, and you turn on the light and there's Johnny, who's 10 years old, and he's having a seizure in front of you. And this is the most likely thing it's going to be if Johnny's otherwise completely normal. 50% of children only have seizures in sleep, and 20% only have wake, and the rest have both. Now, the good reason this is the best one of all the epilepsies to have is that 20% of children only have a single seizure, so you don't need to treat them. 60% have them infrequently, 20% have frequent ones. Migraine is common for these children, and they have a very classical EEG that is in what we call the central temporal region. So temporal under here, under your temple, and central at the top. And this discharges might be on one side in 60% or both sides in 40%. And here's the EEG, and I just want to show you this to contrast it with the generalized ones. Here you see focal discharges. They're in the left temporal region. They have a very specific appearance that EEG doctors like me like to see, because we say we know exactly what that is. This one is also reflected on the other side, but some of the discharges are only seen on one side. And as I said, in 40%, you might have separate ones coming up on the other side. So in this syndrome, seizures are predominantly in sleep, often just before awakening. You don't treat the first few seizures. But if a child's having seizure once a month, I would treat them, because the parent's anxious and the child becomes anxious. They do very well with carbamazepine, Tegretol, but if they don't respond to that, Epilim or valproate often works well, and they grow out of it by their mid-teens. So that's the very mild focal epilepsy. What about the severe ones? Well, with more of a structural abnormality, and that's most of the rest of the focal epilepsies. You don't always find a structural abnormality, but you might find malformations or acquired abnormalities of the brain, structural changes, such as a tumor. That tumor might not be malignant, so don't always go, tumor, oh, that's terrible, because it may be what we call a benign tumor. So it's not going to get worse, but it may need to be removed for surgery, for epilepsy control, or a scar, which is quite common. So the syndromes, these epilepsies, are defined by the type of seizure, where it comes from in the brain, and the cause. Again, similarly, they have focal seizures or focal to bilateral tonic-clonic seizures. They may have an aura. The seizures are stereotyped, but here they may have evidence on their EEG or on their MRI of an abnormality. And these discharges might be focal, but they might be one, or they may be multifocal in several places. Some people are easily controlled, and some people are very hard to control, and we might think about epilepsy surgery. And these are really named according to which part of the brain. Are they in this purple and blue area, which is the frontal lobe? Are they in the pink area, the parietal lobe, the occipital lobe at the back of the brain, or the temporal lobe, the yellow? So I'm just going to talk about temporal lobe epilepsy because it's the most common. They often have an aura, which is the same exactly as a focal aware seizure. And this most commonly might be a funny feeling in your tummy. Remember the boy that leant forward? And a feeling in the top part of your tummy, which we call the epigastrium. It's a rising up. They may even do this with their hands. They may have other feelings. Autonomic, again, refers to automatic things in your body like nausea, deja vu, nausea, goose pimples, those sorts of things. You can have psychic or sensory problems, auras. Deja vu I've talked about, where you feel like you've been somewhere before. You may have things going too fast or too slow, or closer or further away. So other types of perceptual changes. You may smell things that aren't there, or you may hear things that aren't there. And this focal aware seizure can then progress to lose awareness, where the person stops and stares. That's called a behavioural arrest. They may have those automatic movements I've described before with their mouth or their hands, or they may have an upper limb dystonia. Dystonia means abnormal tone posturing. I'm showing you one with my hand, and we saw one in that first little girl, and I'll show you another picture of one a bit later. Now, temporal lobe epilepsy, the most common abnormality we find is scarring of the middle part of the temporal lobe. And on this MRI, which is a cut like this through the brain, we can see here that the middle part of the temporal lobe is scarred, and this is called the hippocampus. And here you see the hippocampus on the normal side, and you can see it's a little white line through it, which we can see under the microscope really beautifully. And on this side, it's destroyed, and there's fluid filling the hole now. The black is just fluid, the cerebrospinal fluid in which our brain sits. And you can see, in fact, the whole temporal lobe is shrunken with fluid around it compared to the normal side. So in terms of focal epilepsies, different parts of the brain show different features. So I've already told you temporal lobe seizures are quite boring. People just stop and stare. Frontal seizures might be these hypermotor seizures, or the asymmetric tonic seizure that I showed you at the beginning in the painting by Raphael. And parietal seizures often have a sensory aura, like a tingling or numbness. And then people might have a tonic seizure, and an occipital aura may have occipital seizure, may have a visual aura. So you're almost at your tea break. If you're still here with me, congratulations on that. And I just want to show you one other resource. It's called www.epilepsydiagnosis.org. It's from the International League Against Epilepsy. You can go in there and learn more about each seizure type. You can see the EEGs. You can even see videos. You just need to register, which takes like 30 seconds. And then you can watch 10 videos of absence seizures. There's also a great section on things that look like epilepsy but are not. Now we're going to move on to discuss the investigations that are performed with children and adults who present with seizures. And this slide, which comes from a retired neurologist, Kevin Collins, I think just shows how important it is to get a good history. Nothing is more important than hearing what the person was doing at the moment that they had their episode, is what might be triggering episodes if they have many, and taking a very careful history. And epilepsy is not diagnosed by an EEG. An EEG merely gives you supportive evidence. Epilepsy is diagnosed on the basis of the events that you see. So what do you need? First and foremost, you need an eyewitness account. So if the episode has happened at school, I need to speak to the teacher or get a very detailed description from the teacher about what she saw or he saw, but or the parent. The patient themselves usually can't tell you. So eyewitness account is absolutely critical. And that's where the smartphone is been transformational, because you can capture some episodes, and that really can, a picture tells 1,000 words. Okay, so you do a clinical assessment and you think, yes, it's likely that this child's had a seizure. What's the next step? Well, then we go to the EEG, the brainwave tracing. And these days they routinely involve hyperventilation, which is where you overbreathe for 3 minutes, except in the last 6 months, because with COVID-19, all the laboratories have stopped doing hyperventilation, but I'm sure this will come back. And the purpose of hyperventilation is to try and trigger an episode. It's best for triggering absence episodes. But that only works if the child does a good job of it. So if they do a little bit and stop and muck around, it's no good. But if they do really good 3 minutes of then if they do have typical absence epilepsy and they're not on medication, it should trigger at least some epileptic activity. So hyperventilation is very important for absence epilepsy, most important for that one. But at the moment it's on hold. The other thing that we always do is intermittent photic stimulation, which is the flashing light, to look for evidence of photosensitivity. Now, a point to make there is that people often think they're photosensitive because they don't like bright lights, but that is not the same thing. Many people don't like looking at lights like that, but they don't have photosensitivity. You only have photosensitivity if those lights trigger seizures and if we see the epileptic activity come up with the flashing light. So it's really important to distinguish that. And here you see a lovely old picture that I like to show. It's my colleague, Professor Sam Berkovic, when we were on our first field trip for my PhD research, which was a long time ago now, when we described a disorder called genetic epilepsy with febrile seizures plus, and we went to the centre of Victoria to study a fantastic family. And we set up in a bush hospital, and there we're practicing with to check the EEG works with one of our very senior EEG technologists at the Austin, who's still there, and one of our nurses, and Sam was having a practice run. So this is the routine EEG, and then you might see, you've seen this before, generalized epileptic activity involving the whole brain, focal epileptic activity involving just parts of the brain. And the regular EEG involves these 2 points, the hyperventilation usually and photic stimulation. But if that comes back normal, what does it mean? Well, it certainly doesn't mean that you do not have epilepsy. It's only 20-25 minutes of brainwave time, and you may not happen to have an epileptic discharge in that time. So the next step then, if we're really chasing a diagnosis of epilepsy, which we normally would be, is to go for a sleep-deprived recording. We used to do sedation, we don't do them anymore, but sleep-deprived is where you have less sleep than usual. If it's an adult, you'd keep them up all night. For a child, you might just shorten their sleeping period. And the idea is that the sleep deprivation brings out their epileptic activity, but as well, which we call epileptiform activity, that's the proper term, but I tend to use the simple term epileptic activity. And then if they go to sleep, all the better, because that also brings out epileptic activity. And importantly, EEGs just provide supportive evidence for epilepsy. They do not make a diagnosis of epilepsy. And you can have epileptic activity in people who never have epilepsy. So it's you really have to understand it very carefully. Now, if you have one of the idiopathic generalized epilepsy syndromes that I've just described before, with those 4 boxes, no further tests are needed. You have your diagnosis. It's time to get on to treatment. However, if you have another form of epilepsy, the next step is a magnetic resonance imaging scan. Now, everyone likes to use the term CAT scan, but unfortunately, a CAT scan is out of date for epilepsy. It doesn't show us anywhere near enough definition of the structure of the brain. The structure of the brain is what we want to get to, and a CAT scan hasn't got enough resolution. So why is an MRI important? Well, it shows us the structure of the brain. In fact, I use an analogy of how the house is built. Is it built right or is it built wrong? And so I'm going to show you several abnormalities of structure of the brain. These are different people. Their scans are through the brain at this angle. And you can see here the little arrows pointing to abnormalities of where there is some abnormal grey matter lining the ventricles of the brain. And these are little neurons that haven't migrated outwards, as I described before. They got stuck. And these are different sequences of the MRI. And that's just to show you that we look at the MRI in many ways. And in some ways, the grey matter is grey and the white matter is white. But here you can see the grey matter is lighter grey and the white matter is darker grey. And that's telling us about the different properties of that tissue and helps us to figure out, is it blood, is it brain, is it tumour, etc. So that's the idea around there. And you can see here these little nodules. These are called periventricular nodular heterotopia, but all that means is abnormal nodules of grey matter, of cortex, are different in different people, all caused by a specific gene that we were involved in describing with Harvard many years ago. So I just wanted to say there are many ways we use MRI now. That what I've been showing you to date are the normal ways, but it is important that the MRI request form says an epilepsy study, because it's different to a routine MRI looking for a tumour or multiple sclerosis or many of the adult issues. So it needs to say epilepsy. I've already shown you how different sequences look different and tell us different things. We also have special cuts to look at the different parts of the brain, such as the temporal lobe. And we have special, very fine, very high resolution cuts on a 3 Tesla MRI, which is now the normal level of MRI we use for epilepsy. So if you haven't had a 3 Tesla and you have focal epilepsy, that's worth getting. And we're looking for subtle areas where the brain's not formed right, very subtle areas. And then we have these very pretty surface reconstructions and other whiz-bang things, but they actually are only useful really for surgery. The other normal things are more important. Now, there are many research tests, functional MRI, which are no longer research but important for surgical workup, which I'm not going to go into, but another level for those facing surgery. So just to compare a few different MRIs, you've seen many of these before. The scarring of the temporal lobe, it can be subtle and missed. This is not a subtle example, but important. This is a special temporal lobe cut like this. So here you see the scarring of the hippocampus, the middle part of the temporal lobe on one side. But here is one of my adult patients I just saw a few weeks ago, and she has scarring on both sides, where on this sequence, this is high signal, and on this sequence, it's small and thin and wasted away. And this means this adult can't have epilepsy surgery because she would have no memory left. So if you have it on both sides, you can't operate. And then you've seen this one already before, which are 2 different brain malformations. I'm just putting them all next to each other so you can see the different sorts of things we look for. So once you've done a structural MRI, for more than 80% of patients, you're done and dusted. No further investigations are necessary in terms of taking the epilepsy further forward. But if you have a focal epilepsy and it's not controlled on anti-seizure medicines or anti-epileptic drugs, anti-seizure medicine is a new term, anti-epileptic drugs is just going out of fashion, then we go to the next stage, which is video EEG monitoring. And here you see my monitoring suite at the Austin, and the child has their own room. The parent has a very comfortable bed to sleep on, and the parent has to be with the child 24/7, or a carer who knows the child well, so that they can press the button for when a seizure occurs. Here you can see this little girl has got her electrodes on her head. It's all wireless. Here is the camera filming her activities and the microphone, and basically they come in from Monday to Friday and we record the seizures. Right now we're camping in another ward because of COVID, but this is our usual lovely ward with a view to the courtyard. So why is this so good? Well, long-term video EEG monitoring is a 24/7 study, and you're trying to get these episodic behavioural events to figure out, are they seizures or not seizures? Now, that in itself is really important. It can be that even in a person with epilepsy, you're looking to see if some of the events are epileptic or not, because you would treat the epileptic, but you wouldn't treat the non-epileptic in the same way. If somebody has very uncontrolled seizures, you're trying to figure out what type of seizure is this, or do they have many types of seizures and what do they have? And if you're thinking about epilepsy surgery in that last 5% of patients, you must do long-term video EEG monitoring. It's expensive and time-consuming, many thousands of dollars a day, but cost-effective when we use it well. So if you actually sort out that somebody doesn't have epilepsy, they don't need anti-seizure medicines, isn't that fantastic for the child and the family? And then with these children which need the next level of investigation, or the adults indeed, They have to have high level 3 Tesla, that's a high level MRI. And then we talk about functional imaging. So we have structural imaging and functional imaging, which looks at how the brain is functioning. In SPECT, we look at the blood flow to the brain. And in PET, we look at how the brain cells eat up or metabolize glucose. So rather than how it's built, we're looking how does the brain function? Can you actually move through the doors and windows as you're meant to, just to continue my analogy? Now with SPECT, it's time urgent. So this is an old picture, but a goodie, from my colleague Mark Newton, who's an adult neurologist, recently retired. And here, this is from his PhD. He showed that if you did the SPECT study at the time of the seizure, you got much more useful information. So here you see him running to, the patient's had a seizure, someone's pressed the button, called out, he's run to get the radioactive isotope. He's injecting it into this patient with the nurse holding the arm. And now our nurses do this. They're fantastic at it. You then have 2 hours from that injection. It lodges in the brain within 30 seconds. Then you have 2 hours to take the patient down, get their nuclear medicine study, and then get a lovely picture of the blood flow to the brain at the point of time of the seizure. So SPECT is a cerebral blood flow study, so blood flow to your brain. We use something called ECD nowadays. We used to use Serotac. It has this first pass, so you inject it within 30 seconds, it's lodged in the brain and gives you a picture of the brain at that moment. And you then, and Mark in his PhD showed that ictal studies, that means ictal means during the seizure, are much more powerful for telling us where the seizure is coming from than between seizures or immediately after seizures. And indeed, this figure is from Mark's PhD, and you can see what he termed the golden globe. And these are cuts through the brain at this angle. And you can see here the temporal lobe of the patient here is all lit up, and it's a golden globe. Between seizures, it's down a little bit. It's bluer than on this side, which means down. And then during the seizure, it's way up here, but also down at the back. And then immediately after the seizure, it's down in the middle part of the temporal lobe. It's still up in the middle part of the temporal lobe and down around the outside. So we know we need to have the video EEG to understand how to interpret the finding of the scan. And here you see an example of that interpretation. This SPECT scan is at this angle, so different angle. And you can see here that the left temporal lobe is way up in this adult with temporal lobe epilepsy. And she's got a dystonia, abnormal tone of her right hand. And we know if that happens early in a temporal lobe seizure, it can tell us which side it comes from. We call that a lateralizing sign. And so in this seizure, she has a right hand early, and an early injection shows you the seizure is coming from the left temporal lobe, which is very important if somebody has drug-resistant epilepsy, the drugs don't work, and you're thinking about whether they could be an epilepsy surgery candidate. So in a PET study, we do functional imaging. So that was SPECT. I'm moving to PET now. This looks at brain metabolism. It uses radio-labeled glucose called 18-FDG. We can't do as much an injection during a seizure unless someone's seizing all the time, but we can do it in somebody who has active epilepsy to try and find the bit of brain that's not working well. And this has a short half-life, which means you've got 20 minutes from injection to it needing to be into the patient. Sorry, it only lasts 20 minutes. So from when it's made up, you have 20 minutes, you put it in the brain and into the IV in the patient, and then it's taken up into the brain over 20 minutes. So it doesn't give you a moment like the SPECT, it gives you a 20-minute period. And if you have frequent epileptic activity, as we see in many of the children with severe epilepsy, you need EEG at the same time during that 20-minute uptake phase in order to understand the scan. And what I mean by that is if you're catching somebody between seizures, they will have low metabolism. If you're having someone during a seizure, they will have increased metabolism. So that's why you need the EEG in the children with very active epilepsy in order to understand what you find. And you're looking for differences between the two sides. We often focus on the temporal lobe because many uncontrolled focal epilepsies come from the temporal lobe, but we also look at extratemporal, which means other parts of the brain. So let me show you a few examples. This is a cut like here, and you can see here that this left temporal lobe is way down compared to the normal side. So this is temporal lobe hypometabolism, and the PET scan is telling us, look, that left temporal lobe just isn't behaving itself. Now, I look like I've got the side wrong, but this is the siding that's being shown to us. Now, this is a rare one. It's a 4-year-old child who had constant epileptic activity. So, in fact, his is increased. And this study through here is like axial, is what we call it. And here you see the PET study. And this area is constantly hypermetabolic. It has increased glucose metabolism. And this goes with an area of brain malformation. This is the same study, but a cut through here, showing again that around here, this has increased activity. And this one is like this, again, showing that along here, we have increased activity. And this child went on to have the frontal lobe removed with some improvement, but not total improvement and this area was malformed, which we call dysabnormal plasia formation. So when we think about the imaging in patients with drug-resistant epilepsy, so uncontrolled focal epilepsy, we want to put a whole lot of the imaging together and see, does it all tell us the same story, or do the studies tell us different things, which is more of a red flag to surgery? So here you see there's a patient here with hippocampal sclerosis. Their PET study, the metabolism study, shows that this PET study way down on metabolism. And the SPECT study during the seizure shows it's hot, and between seizures shows it's not working properly. So these 4 studies all tell us the same story. The mischief, the problem is in the left temporal lobe. And if everything, the video EEG works and shows us the seizures are coming from there, then this person may be an epilepsy surgery candidate. But wait, there's more that we need to do. We need to think about the neuropsychological findings in patients that we're thinking about epilepsy surgery. And you're going to hear from my fantastic colleague, Dr. Silvana McAuliffe, this afternoon, who'll talk to you about learning problems in children with epilepsy. But just speaking specifically about where we think about it, well, no, I think about this for all children with epilepsy, but even more so for those going to surgery. Many of the children have subtle learning problems. They're often unrecognized. People just go, oh, Johnny's got epilepsy. But Johnny may have learning problems in addition to epilepsy, so they coexist. They can be worsened by the seizures because they lose awareness, they've missed something, but they're often there as well, and they're often unrecognized. Now, by getting your fantastic neuropsychologist to see the child, they can provide strategies to help learning at school. They can support applications for assistance in the class with an integration aid. They can advise you by understanding your learning problems. It can actually help your self-esteem because you can say, well, look, I know I'm not good learning that way, but I can learn this way. And we're all like that. We all have our strengths and weaknesses, you know. I'm not meant to be an Olympian. I know that. And so understanding that about yourself really helps. The other thing is that the neuropsychologist can retest your child when the seizures are controlled and get an understanding of what their basic learning abilities are like. And again, please ask Silvana more about that this afternoon. So when you're thinking about it for surgery, we are looking at the neuropsychology to try and tell us more about where the seizures might be coming from. So does the child have a memory problem? We know the temporal lobe looks after memory. If it's a verbal memory problem, that often sits in the left temporal lobe, which is the left hemisphere is your dominant side and controls right-hand movement. So most of us are right-hand and we are therefore left hemisphere dominant. So if I have a problem with my left temporal lobe, I might have a verbal memory problem, Whereas if I have a problem with my right temporal lobe, I might have a non-verbal memory problem. And that might show in poor sense of direction, not being able to follow a map. Whereas verbal might mean I don't understand what you've told me. Again, I'm sure Silvana will talk about this far more eloquently than I will later today. She can then tell us where in the brain the seizures might be coming from the neuropsychological point of view. And also, what are the risks post-operatively? If we take out this temporal lobe, is this person going to be at risk of a memory problem, or do they already have one? It really won't get any worse. What should we look for? They will review the patient post-surgery and also guide expectations and help teachers. I use their reports all the time, and I encourage families strongly to share reports with teachers every year so that the teachers can understand that the student in front of them. And then the final part of the puzzle is the psychiatry. In patients with epilepsy, there's an increased risk of increased existence of psychiatric problems. The most common would be depression, but you have other issues like autism spectrum disorder, psychosis. Psychiatry is really important to look at the patient's expectations of surgery. So are they expecting this will change them into the life at the party when they're a quiet person? Because that's not going to happen. But how are they seeing it will change their life? With the adults, they often think, I want to drive. That motivates them, which is fantastic. But they also think they'll throw away their medication. And that's often not the case for the adults. They often will need at least one medication for life. Whereas for the children, they may be able to slowly and carefully, with guidance from your neurologist, get rid of the medications. So what are we expecting? What's the likelihood with surgery of being seizure-free? Often the best you'll ever get is an 80 to 90% chance of marked improvement, which includes seizure freedom or a marked reduction in seizures, but no one can promise seizure freedom. And the other part is really important psychosocial support. And fortunately, in children, we're often very lucky because families there and they offer fantastic support. The adults are often not as fortunate. Their families may not be as supportive. But with children, we have to all come along through this surgical question together. So epilepsy characterization, and particularly pre-surgical characterization, is a multi-pronged approach. We look at the clinical features on video EEG monitoring, the electrical features, MRI, SPECT and PET, so structure and function, neuropsychology, psychiatry and social support. And the question we ask is, do the ducks line up? And if all the ducks line up and tell us that the epilepsy is coming from one part of that brain, of the person's brain, and that then we're beginning to say this person could be a surgical candidate. So then we're saying, do all of these 8 issues agree on where the seizures are coming from? And will the patient and his or her family cope with epilepsy surgery? And sometimes I found that my parents of adolescents aren't ready to cope with epilepsy surgery. And then when the adolescent hits 18 years of age, they say, I want the surgery. And the parent's been a bit slow to come to the table. So I think we just need to think it's really important that we do the best by our children and our adults and offer them the best. And if surgery is offered by very great experts, and we have fantastic epilepsy surgery team at the Royal Children's Hospital in Melbourne, headed by Simon Harvey, if they're offering that in a child who's younger, it can be transformational and can certainly help them to be able to grapple with what they have, to be able to learn, develop and do really well and turn their whole lives around. So it's scary, but it's also a fantastic opportunity. All right, that's the end of all the tests. Let's move on to treatment. And as I said, I'm not going to spend too much time on specific drugs, but more about principles. So the first thing is I've got the word counselling. I suppose that means really about diagnosis. I don't mean how are you feeling today. I'm merely talking about the diagnosis. What sort of epilepsy does the person have? What can we expect? Will they grow out of it? Will it be around forever? How much will it limit their life? Whatever is a treatment, whatever side effect. I think an incredibly important issue is drug interactions. So if you have a child who's on anti-seizure medicines, every time your GP prescribes another drug, you need to ask the pharmacist, is this drug safe with the one my child's on? And you need to say to the GP, my child's on Tegretol, is that okay? And the GP may not know and ask you to check with the pharmacist. You need to understand how to manage their seizures. You need to think about the implications for driving, employment, leisure activities, and for inheritance. And these other issues are important. And as parents of younger children, you think, oh, this doesn't matter so much. But with driving in a younger adolescent, a teen or a tween, you often need to think about it a bit ahead of time so that they've had enough of a period seizure-free to start going for their learner's permit at the right time. And by that, I mean, you know, weaning medications, seeing if the seizures come back, or if you want to wean the medication before they drive, you need to think about that ahead of time and talk about it with your doctor. The other issue is employment. What can my child not do with epilepsy? Well, they can't be an airline pilot, so it's good to steer them away from that, but they can do most other things. Will my child be able to have children? Absolutely. Most people with epilepsy can have children, and their children are only at a low risk of epilepsy. Sometimes that's not the case, but that's normal. So let's turn to what do you do? What do you do if a child or an adult is having a tonic-clonic seizure? Well, the safest place is the floor or a soft surface such as a bed, a chair. If they're in a chair and they're not falling, you can hold them so that they don't fall. But once you're on the floor, you can't fall any further. The position you need to be in is the coma position. Now, if it's a small child and they're fitting, you can turn them over, as you saw in that video. If it's a big adult, you don't want to break your back, and you could. So wait till the seizure ends, which is when the stiffening and jerking stops. But often at that point, the breathing might become quite scary. They might start going, and it might even sound scarier than the seizure. And this can be because the tongue, which is a great big muscle in the back of your mouth, is blocking the airway. So then it's time to try and turn them onto their side. The key to this position is this shoulder that the person is lying on. And if that's pulled back, I flipped it forward. If that's pulled back a bit backwards, then everything else will fall into position. And the important thing is to have their head on the side, not the hand. I don't think that's necessary, but if their head's on the side like this, the jaw will fall forward, as will the tongue. They will dribble, and if they've vomited, any vomit or dribble will come out. If they've stopped being tense and the mouth isn't tense, you can put in your hand and get out any vomit that's there. If the mouth is still stiff, they're probably still seizing, and you should not put your finger in there because people have had their fingers bitten off. Or a silver spoon, that's an old wives' tale. Never do that. Just put them into this position. And if you have the wherewithal, putting the legs like that helps with the posture. But the key is the shoulder that they're lying on, which should be back a bit further, and the rest is right. Some people worry about should you have a pillow or no pillow. Doesn't really matter. If you have a pillow handy and it's not one in which they could suffocate or anything, but it's fine to use it, but you don't need to get it. The most important thing is to stay with the patient. Do not make sure they're fine until they've recovered. If they're standing up and having a focal impaired awareness seizure, you don't restrain them, but you move them if they're in danger. Say they're holding a cup of tea or a scissors, you take them out of their hand if you could. You don't force open the mouth. And I've just shown you the recovery position and clearing out the airway. And obviously, if a seizure continues, you should be calling an ambulance if a seizure is going more than 5 minutes. Often with a tonic-clonic seizure, you'll call an ambulance the first time, which is completely reasonable because it's very scary. So what about preventative measures? And the word we use medically is prophylactic. And you minimise triggers relevant to the patient. So most people, if they're unwell or they're tired, will be at risk of seizures, or if they have stress. Fever in younger children particularly will trigger seizures. You try and minimise that with some paracetamol. If people are photosensitive, you take them out of that environment, but most people are not photosensitive. You try and make sure they have enough sleep. And in adolescents and adults, obviously high levels of alcohol are a risk for triggering seizures. What about important two other lifestyle issues that are critical is swimming. And if you swim, you should have one-to-one supervision if you're swimming and you have active epilepsy. So if a child is in the pool, I say to families, you need to be on the edge of the pool watching your child, be you a mum, a dad, a grandma, or someone, a carer. But if a child is very, very frequent seizures, you need to be in the water. That's for a swimming pool. With the beach, particularly with a surf beach, you need to be next to the child, because surf is particularly dangerous because, of course, if a child has a seizure and goes under the surf, you have trouble trying to find them. The other major piece of advice is around bicycle paths. You do not ride bicycles on the road if you have epilepsy. You can imagine you'd sail straight into a car or go across when a car's coming. That could happen into a tree in the park, I guess, but it's about balancing risk, benefit, and lifestyle issues for people with epilepsy. Now, I'm a major fan of this, a seizure diary. Now, this is it, particularly if you don't have seizures all that often. It's one page for 6 months, and you just put the year in it. The other side of the page is the other 6 months. You can download this from both the Austin Epilepsy Program and the Royal Children's Hospital Epilepsy Program. And then 10 pages, you have 10 years, and you can show whenever seizures occur. Now, many people, this is a fantastic record. I know there are lots of apps. I don't think the apps are nearly as good as the paper, because I can look at it and you can look at it and we can go, look, this drug's made no difference. It's exactly the same as it was a year ago or 3 years ago. Or, wow, this has made a huge difference. Sometimes people have many seizures a day, and that gets very hard to record. Many of my families are fabulous at doing this. But another strategy might be that you, if a child has lots of absence, you might record 15 minutes over dinner every night and just have a running number of that, of seizure numbers. The other thing you can always do with these forms is put when a drug was started and finished, and then you have a long-term record. So really a seizure diary, I find, is a fantastic ongoing resource. And most of my families are just fabulous. They keep them and they know how much use they are. And I think they see with time, because you just can't remember, particularly when you live with someone. There are other important lifestyle issues in managing epilepsy. One is about having routines. So making sure you give your medication on time. It doesn't have to be to the minute. So it's sort of, if you're having epilepsy medicines twice a day, which would be normal, I would say somewhere like 10 to 14 hours apart, often with meal times. But you have to make sure you don't forget, because many people, when you forget their medicines, have seizures. Sometimes it's good to document that you've given a drug. One example is where you have shared care. So you have divorced parents and they share the care, and they may take the child at 6 p.m. and then mum might give it, hand over the child to dad, and dad gives it again. So just making sure you know what you've given. In children in care, this would be routine, but fortunately most children are with their families, which is where they should be. And then minimize trigger factors. So we've talked about tiredness and flashing lights. I put minimize stress here with ... because sometimes parents tell me that their 6-year-old has no stress at all. And I think you've got to remember their stress is quite different to your stress and my stress. Their stress might be that their best friend's not talking to them. Still a stress, but something that matters to them. So it's impossible to get rid of the stress in life, as we've all found this year, I know, but I think it is important to try and think about minimizing it. Other lifestyle issues, and the Epilepsy Foundation can certainly help with these, are around safe issues in the home, such as running the cold water first in the bath. And that way, if the person falls in during a seizure, they won't burn themselves. Using a non-slip mat on the bath bottom, looking carefully at water levels. They've got lots of ideas around this, and I would encourage you to look at their resources. So just to finish up my last few slides, we need an epilepsy type or syndrome diagnosis, and that tells you which anti-seizure medicine we use. With generalized epilepsy, we start with Epilum or sodium valproate, except in women of childbearing age, but certainly in children and in males. Focal epilepsy, we start with carbamazepine or Tegretol. It's very important to start low and go slow because you want the person on the minimum effective dose. And very important, only to change one anti-epileptic drug at a time, because if you change two at once and the child gets worse, you don't know whether the one you were using was doing more than you thought, or whether the one that you were introducing was bad for the patient. So only do one child at a time. All patients with epilepsy, if we look at the whole picture, 80% are fully controlled on one drug, 20% require more than one drug, and within that 20%, 5% need full pre-surgical characterization, which are all the tests I've just described. So this is my last slide, and just to say, this is one of my wonderful adult patients who I met. She's one of the ones where the surgery was not allowed until she was about 18. And she is on her 21st birthday there, challenging epilepsy. She's an amazing young woman, and it just shows how important it is to ensure your child or the person you live with epilepsy has the best possible quality of life.